Hi, I'm Dr. Suchitra. In this session, I'm going to talk to you about spondyloarthritis. This used to be called seronegative spondyloarthropathy, but arthropathy doesn't show that there is a lot of inflammation happening. So they've changed it to spondyloarthritis. And the seronegative used to mean that rheumatoid factor was negative in these patients, but there are a small group of patients with spondyloarthritis who may have rheumatoid factor positive, and even in the general population, rheumatoid factor can be positive. So they've taken that out of the name. So it is spondyloarthritis now. This is a group of related disorders, but with phenotypically distinct features. These are the conditions that come under spondyloarthritis. Ankylosing spondylitis, which is the best studied. There can be reactive arthritis, spondyloarthritis associated with psoriasis, spondyloarthritis associated with inflammatory bowel disease, undifferentiated spondyloarthritis, juvenile onset spondyloarthritis, and non-radiographic axial spondyloarthritis. The prevalence seems to be about 0.5 to 1.9%, and it seems to be increasing on the whole. This is a different classification criteria proposed by the Assessment of Spondyloarthritis International Society. They divide spondyloarthritis into predominantly axial and predominantly peripheral. When we look at ankylosing spondylitis, which is the classical spondyloarthritis, the male to female ratio was thought to be 10:1, but it's actually much lower. It's only 2 to 3:1. But since it was thought to be this has caused delays in diagnosis in women with ankylosing spondylitis. So the ratio is not as skewed as you would think it would be. The main features are axial involvement, that is the spine involvement. There can be peripheral arthritis. Enthesitis is a very important feature, and there are various points of enthesitis, mainly Achilles tendon insertion and plantar fasciitis. There can be dactylitis, which is involvement of the whole digit, fingers or toes. The whole digit is inflamed. It's tenosynovitis, synovitis, and there is swelling in between the joints as well. There can be uveitis. These are main features. There can be other features as well, including iotitis and atypical pulmonary fibrosis. These are the several classification criteria. There are quite a few, as you can see. But what you need to know is all of them seem to rely on inflammatory back pain. And back pain is such a common problem that to distinguish it from inflammatory and non-inflammatory requires a clinician to be vigilant. So back pain, which is severe on waking up, that is after rest, after they've been asleep all night, it is severe on waking up and even after prolonged sitting, and it lasts for quite a while and decreases with activity. That's the main feature. It decreases with activity, and they can get alternating buttock pain, and they can get there may be a history of iritis. There may be a family history of ankylosing spondylitis or spondyloarthritis or psoriasis. These are some of the features that help you to think of inflammatory back pain. If the patient is below 40 years of age, if there is an insidious onset, not related to any trauma or not sudden onset, if it improves with exercise, this is an important feature because most other causes of, that is non-inflammatory cause of back pain, will become worse with exercise. This inflammatory back pain will improve with exercise and it will not improve with rest. And there can be nocturnal pain, especially in the second half of the night, which wakes the patient up. So there are several criteria, Callan, Berlin, and the ASAS1, Assessment of Spondyloarthropathy International Society's one. All these try to distinguish whether it's inflammatory back pain or not.